Well, we have a lot of questions that have been flowing in and from many P.A.D. warriors. So I want to bring in Dr. Ali Gulshan with Beach Wellness MD in Orange County, California, Dr. Aaron Armstrong and Dr. Kazar Khan, both from Colorado's Advanced Heart and Vein Center. Let's also bring in our P.A.D. warriors, Douglas and Frank, to help bring us some of those questions, but I'm going to turn it over first to Dr. Ali Gulshan to kick us off. Dr. Gulshan, thank you for joining us on this Saturday.
Tim, thanks so much for having us. I'd just like to echo the statements that Dr. Runback, Beasley, and Joy made. Really, impressive what you do, and you help patients, and thanks for having us.
Fantastic. So I want to jump in. I'm not sure if Douglas or Frank has the first question they want to bring to the table. Hi, Dr. Armstrong.
I think so. One of the things I think in your local area, if there's any university, I think that's one good resource that you may want to check with. Usually they're involved with all the research trials. So university usually is. And then I think we're usually asking the people who are the, experts like Dr. John Runback and asking him, reaching out to him, hey, any locally. Dr. Mustafa, he's also one of the researchers up in Michigan. And he knows the whole network. So usually guys
we're losing you there.
And I think Kim has been a good resource too.
We do have a question from April about how P.A.D. impacts venous insufficiency, lymphedema. New studies are indicating patients with P.A.D. need to also talk about vein health and other issues with their vascular specialist if presenting with additional symptoms.
Yeah, I could take that. It's interesting because I think in the vascular space, many of us focused on arterial disease first, and it's been, as we know, well established that not getting blood flow down to the legs is very important for wound healing and for symptoms of claudication as well. But more and more, I think we're realizing that a lot of people who have arterial disease also have venous disease, because a lot of the same type of inflammation that can lead to arterial disease can also injure the valves of the veins or also cause issues with blockage in the veins farther up. So I would say that at least a third of the time, people who have artery disease also have vein disease. And we typically address the artery disease first. But if you're still having symptoms after having your arteries treated, I think it's very important to talk with your doctor about whether you might have vein disease as well, because it's very otherwise unrecognized. And it's, if you think that the area of arterial disease is evolving and there's less knowledge about it, vein disease is even maybe 10 years behind that. So that's it's a really good question.
And what are some of the treatments? I know that Dr. Ali Gulshan is on the cutting edge of some of the newer treatments for chronic venous insufficiency. And we still see, Dr. Gulshan, so many doctors just saying, oh, we'll go home and wear compression socks. But that's not as easy for a P.A.D. patient, in which it can be contraindicated at the higher compression levels.
Yeah, I'd just like to echo Dr. Armstrong's comments. Venous disease is so common. It's so much more common than arterial disease. And the reality is that obviously if you have, critical ischemia, an ulcer in your foot or rest pain, and you have arterial disease, it's very important to treat it quickly, treat it first. But there are many patients who have mixed disease, arterial and venous disease, and many patients who just have venous disease and don't have arterial disease, and they have non-healing wounds. Non-healing venous ulcers are the number one cause of lower extremity ulcers in wound care centers. And so it's really important to recognize what that lower extremity venous disease looks like. And it's so common for physicians that don't work in the venous and vascular space to just basically, not look at the legs because they're busy with other things, or if they look at it, not recognize that it's a common treatable condition. So if your legs have discoloration, if it looks like they're dark around the ankle, if there are wounds around the ankle, if there's pain or swelling or heaviness or aching or restless legs, those can be signs of venous disease, and it's very easy to diagnose with an ultrasound. And really fixing that venous disease is a very simple, non-invasive procedure. I mean, these procedures that we do on the arterial side, it's amazing how they can be done outpatient. But man, if you think those are simple, the venous procedures are so easy. It's a 15, 20-minute in-office procedure, no anesthesia, you're in, you're out. And we're so good at getting rid of those bad veins now. We have so many tools in the toolbox, new ones coming up. And really, it's important to get your venous care, but you have to be your own advocate. So really just use resources like Kim and reach out to us and ask, what's my venous disease symptoms going to be like? And then ask the physician to look at it. Because it's true that a lot of people really focus on their arterial disease, unlike, say, Dr. Armstrong, who's, comprehensive and takes everything into account. Some vein doctors don't treat arteries. Some artery doctors don't treat veins. And so you have to advocate for it. You have to mention it. You have to bring it up and really push for them to take a look at it because it can be missed and it's just so common.
Yeah,
And
I just
it's
wanted
really
to add on.
important.
Yeah, that
Go
I think
ahead.
in our patients, we typically screen for both, actually. That's a very common, 80% of our patients, we screen for both arterial and venous. So you should ask your doctor to be screened for both.
And I think it's
I
really
do.
important. We still have actual doctors that are still stripping the veins. So it's important to give some of our warriors here an indication as to what some of the other options might be that are less drastic.
Yeah. So the big buckets of venous therapy. So basically it's all about the valves, right? Elevators have floors for people, veins have valves for blood. Valve shut, blood goes up. If those valves fail, the blood goes down. It's like a tree. It's got a trunk. If the pressure builds up in the trunk, the branches start to swell and you get those issues. So you want to take out the trunk. You want to close that bad vein with the bad valves and get the blood to go up good veins with good valves. And your options are heat, which is called thermal, which means you burn the vein shut by putting in a catheter, but that requires lidocaine to insulate the adjacent tissues. There's a glue called Venocil, which glues the vein shut. It uses no heat, but it is a permanent foreign body. There's a foam, which is a Varithena, which is an injection that goes in and chemically cauterizes the vein. And then there's something called MOCA, which is mechanochemical ablation, which is a twizzly wire with medication after it. Bottom line, all good tools, all very effective in the hands of the right interventionalist who's familiar. They all work. They're all minimally invasive. Some have advantages over the other. But really, again, I mean, with calcified arterial disease and these deep venous arterializations, there's just so many challenges of keeping these arteries open and getting the flow. With veins, they're easy to treat, they're easy to close, they're easy to retreat. So really, the treatment options are there and they're very effective. And so that's the nice thing about it. And so really the disease should be recognized, diagnosed, and treated. There's no reason that it shouldn't be.
And
We have,
Frank,
yeah,
Yeah, go ahead, doctor.
no, go ahead, Frank.
Oh, hi. How are you, Douglas? Yes. Another question having to do with diabetes. As a diabetic, I'm always concerned about the next operation and the next surgery. And so is the case with Eric. He's a type 1 diabetic who had an angioplasty, much like me, just a few months ago. And he got some advice from his surgeon after an ultrasound. His surgeon said, well, you can always come back after the pain gets too much and we'll think about amputation. And of course, we know that the A word, the amputation option, makes people extremely nervous, especially if they're not aware of other options. So what's the best way to really get that message across about seeking other options and other opinions, because there are other advanced skilled opportunities for unblocking?
yeah, so basically, what are the indications for an amputation? Like, when do you know? When do you know that all efforts have been exhausted, right?
Right.
Dr. Armstrong?
Yeah, so I think that can be a challenging question depending on the specific patient. But I think, what I see time and time again is that, doctors will say there's nothing else they can do. And as Dr. Joy said, they're probably right. There's nothing else they can do. But there are other doctors who can provide options. And I think it's always a good idea to get a second opinion, especially, when an amputation is being discussed. Now, there are cases where, a limited amputation makes sense, because if you get a toe amputation, we have good ways of being able to walk normally and live a normal life. But the reality is, there are a lot of advanced procedures out there that a lot of doctors might not even be aware of. Those include things like the deep vein arterialization that was being discussed, right before this session. But then, there are also doctors out there that aren't comfortable treating tibial arteries below the knee. They don't have experience with it. And even more so, there's probably a very even smaller percentage of those doctors that will treat arteries in the foot, for example, below the ankle. So depending on, but I think the take home point for me would be it doesn't make sense to be living with pain. And so to have the doctor say, like, well, once the pain becomes unbearable, come back to me and we'll do an amputation. there are other options out there, both for dealing with the pain itself, and if the pain is because of blood flow issues, I think looking for a second or even a third opinion to look for options for that makes a lot of sense before committing to an amputation.
Douglas, you have a question?
You shouldn't wait. Like instead of waiting, I'd say go and speak to a P.A.D. doctor. So I think one thing I would recommend following online is it's a hashtag CLI fighters. We all follow them, and they're anti-amputation, and these are all the providers that really post their cases, and they're all over the US. So it's a good one to follow.
Definitely, that's good advice on Twitter. Definitely the hashtag CLI fighters is really a good one. I watch all the cases that are on there. Douglas, another question?
Yeah, let's go back to the basics here. We have a lot of new clients, new patients in the group, and there are people that are along their journey anyway. The question from Kath was, she just started her journey. What does she need to know about when and what procedures should be performed? So for the new ones in the group, trusting what doctor to know what to do when.
I think that's a very important question because there's a lot of scrutiny, especially on the doctors that are treating supposedly too soon, but yet it's so interesting because the biggest problem we have is not treating soon enough, but yet the bigger focus, the big sexy headlines are all on those few that are treating, too soon. And there are some of those as well. So I think it is an important question to ask. At what point do you just stick with medical therapy and walking therapy versus intervention versus surgery? Do you want to start with that, Dr. Gulshan?
Well, listen, I mean, if you have a wound in your foot and there's decreased arterial flow, there's no question that that's a foot emergency. It's the equivalent of a foot heart attack or stroke. So there's no question that that should be treated very aggressively. If you have pain all the time, like when you're sleeping, and that's from decreased blood flow, that's the equivalent of a foot emergency too. Now, if you have pain when you walk and it gets better when you rest, it's called claudication. It means there's no tissue loss or risk of tissue loss immediately. Then you want to maximize medical management. I think like Dr. Runback was saying, really take all of your activities like walking, smoking cessation, taking your statins and your blood pressure medications to put out the fire that's building those blockages. And then if it doesn't help and you still have lifestyle limiting claudication, like Dr. Joy was talking about, or Dr. Runback, sorry, I don't remember, then you want to consider an intervention. But yeah, if you have a wound in your foot, I mean, I think a lot of the people that are CLI fighters, like Dr. Kassar was talking about, critical limb ischemia means a wound in your foot. And the majority of the cases that we do, or a super majority of them, are ulcers. I mean, there's no question that those patients should be treated very aggressively and recurrently if necessary. Sometimes you might have to do multiple procedures or try from a different angle or a different approach or use a different tool. That's okay. When you're doing the toughest cases, it's normal to have to try another technology or another tool or try a second time, right? Because the harder and the harder your cases get, the lower and the probability that you're going to be successful the first time. It's okay to try again. The difference between 80 and 99% success sometimes is trying again or trying another approach or sending it to another colleague that has an expertise or taking consideration for open surgery. So it's just like, don't take no for an answer and keep pushing in those situations.
Yeah, Dr. Armstrong, you want to jump on to what Dr. Gulshan is saying and add to that?
Yeah, absolutely. I think that even the most, advanced physicians of us with techniques that other people don't do, we're not always successful the first time around. And that's for a number of reasons, but, there's ways of approaching blockages, from both above and below. The most challenging cases usually are where, there's 100% blockage of some of the arteries. And that can require sometimes going in from the femoral artery above, or actually going in through the foot arteries in the opposite direction to try to connect the dots. Sometimes we even do advanced techniques where, we'll use needles and catheters to go in the artery right around the level of the knee joint. And so sometimes for technical reasons, you can't do all that in one procedure, and it's necessary to make multiple attempts at doing it. But I think the key is having a doctor who's willing to take the extra steps to try to do those more complicated cases, because there are a lot of doctors out there that treat vascular disease, but they don't have that level of comfort of dealing with complete occlusions. And, instead of putting in the necessary few hours sometimes to successfully get the vessels open, they'll stop the procedure and then may not offer that there are any other options. And so I think all of us who are in the space who treat critical limb ischemia are extremely stubborn, and we don't take no for an answer. And that does sometimes mean multiple procedures as well.
And how often should you get, one of the questions coming in, an ultrasound when it comes to PAD? Because you could be someone that fits into the claudicant category, and you could be told medical therapy and walk, because insurance requires, for most patients, 3 months of a regimented walking program, lifestyle modifications, diet, smoking cessation, etc., prior to any sort of intervention. But you might have a short focal lesion at that point, but by the time you end up getting in to treat them, it might have turned into this long calcified occlusion that becomes your Achilles heel and is much harder to treat at some point. So how do you balance that as a patient? Is this something that the patient has to be paying attention very, very closely to whether or not their symptoms are improving? Or is this something that they should be getting regular ultrasounds to monitor as well? Dr. Khan?
I think there's no standard, for everybody, because, it's a continuum of disease progression. And so somebody may have just, 30-40% blockage. The other one may have like a whole leg blocked up. So I think it's different. The way we see is we tell our patients that if there's a change in your symptoms and you're noticing that things are getting worse, please reach out to me. It doesn't matter if it's been 3 months or 6 months or 2 months. I want to see you and I want to go to the next step. And usually I'll order a CTA or take them to angiogram sooner. So I think I really listen to the patients. So that's why I think, make sure you're very vocal about your symptoms, very vocal about the change in your symptoms to your physicians, because that's what triggers the urgency on our end to move things faster. But on average, I think everybody, for routine screening, we do probably anywhere between 3 to 9 months, depending on how bad the disease is. So, but I think it's the progression of symptoms is that really counts for us.
And Maria, I'm just going to jump to a few more questions here really, really fast, because I have one from Maria and I see this a lot. We see so many advances in consumer devices that claim to improve circulation. What do you think about some of those devices that are out there, including the enhanced external counterpulsation, or EECP? Can it be used to treat and help build collateral vessels for some of these patients? What about something like Revitive that stimulates the muscles in the lower legs and the feet, and even those vibrating plates? How about Dr. Gulshan?
I would say probably save your money, walk, quit smoking, eat a healthy diet, take your prescribed prescription medications by your physician. Just focus on the bread and butter that we know works. Really, I think that, if you're going to be a champion for your interventions, all these cool things that we do at the end of the road, then you should be a champion for your prevention. So I never get the pleasure of meeting you. And that just means, putting out the fire before it starts. So just walk, don't smoke, eat well. And I think people make the false assumption that you have to be perfect. You don't have to go from 0 to 100. Mild improvements are still really substantial. And I try to encourage that with my patients and just talk to them, especially in the beginning. Sit down and talk 15, 20 minutes about lifestyle. Yeah.
This is an interesting one, because I know we have interventional radiologists and interventional cardiologists on here. We don't have a vascular surgeon, but this is from Alex D. How long can a femoral bypass last, and what factors impact the patency rate? And this one's even more, because we always tell patients to make sure that they've exhausted all endovascular methods first, coming down from the top and coming up from the bottom before going to bypass, because when that bypass fails at some point, what are your options after that? So
I could take that.
Okay.
Yeah. So femoral bypass, is an option, and it's important to have that on the consideration of options along the spectrum. I think that I do see people moving away from femoral bypass overall, but there still are a lot of doctors who are kind of old school and do femoral bypass earlier than I think many of us would. So I think it is important to consider all the endovascular options first. There's two main levels of femoral bypass. One of them is from basically your hip joint area or the common femoral artery down to the popliteal artery at the knee. So that's usually used to treat bypasses in the superficial femoral artery. The second type of bypass is called a femorotibial bypass, and that would be a bypass down to the arteries below the knee. The reason that matters is that a fem-pop bypass, the first one, has an okay patency, and by that, it's still not that good. At 5 years, it's probably under 60%. But the bypass below the knee has a patency that very much depends on the surgeon doing it. And I would say that the average patency is only 30 or 40% long term. They do not tend to stay open very long because it's a very small kind of target vessel. But there are cases where, a bypass is the right thing to do, especially when all the other endovascular options have failed. One thing I do want to point out is that there's going to be a new therapy available in a few months called PQ bypass, which is percutaneous bypass. Dr. Joy was actually one of the inventors of it, but it's actually a way of doing a bypass from these same types of endovascular techniques that we do through a same small tube inside the artery. And just like a surgical bypass, what we do is we then put a covered stent from the artery into the vein and then back into the artery. And the initial results of those studies have been very promising. They actually showed patency results that were better than the historical results from surgical bypass. So that will be an additional therapy coming up later this year, especially for cases where every other endovascular option has not worked.
And I think this is a really important question to kind of finish up on before we go into final takeaways. Robert is a runner, had a stent put in that allowed him to keep running. What length of time can he expect this stent to continue to work? He was concerned maybe he got the stent put in too soon. He's never smoked, not overweight, has run 27 marathons. I think the use of stents, less is more, leave nothing behind is really the philosophy. If someone tells you, hey, we're going to go in unless it's the iliacs or aorta, we have a lot of patients where the doctors come and just say, oh, we're going to go ahead, we're going to have you come in, we're going to do an angiogram and we're going to stent you. I think that's a red flag. But I'm wondering, just from your perspective, and I think each one of you should weigh in just on the patency rates of these stents and maybe questions that patients should ask before they get a stent and what they can do to increase the patency of them.
I could start. So, again, I think we believe in less metal is better, whether it's heart, whether it's legs. But I think in general, we know, metal does cause restenosis over time. And there's a risk of that. But I think it is important to have that as a tool in the toolbox, because normally arthrectomy, and depending on what is causing the plaque, is it calcification, is it cholesterol, is it a blood clot, and that determines what is the best treatment for it. And we try to minimize our stent as much as possible. But sometimes we have to put stent, because if whatever it takes in the end to get the flow established, I think we have to do that. And up to 30-40% times we end up using stent because the arteries are not opening up. So having that as a background, I think the length of the stent matters, the amount of disease, the type of disease, the age, the risk factors, they all matter in determining how long the stent will stay patent. But on average, we do think, like around 2-3 years, 80% of stents should remain patent no matter what. We do think that that's the case. So I think that's how we think when we do it. But if somebody says that, I'm going to stent you no matter what, you're right, that's a red flag. We should be thinking stent only if it's needed. So I think that's how I would say. I don't know, Dr. Ali, what would you say?
Dr. Kassar, I completely agree with you. First of all, obviously, no foreign body is always better than a foreign body, because foreign bodies break, they have allergic reactions or, inflammation, which causes narrowing in the artery. Not all stents are created equal. Supera is a stent. It's kind of like a slinky. So it bends and takes the form of the artery, because the artery isn't this static thing. It's very dynamic. It twists and turns and there's forces on it. So the Supera is a good stent. Drug-eluting stents also have better long-term patency than standard, nitinol stents. And then there's other things to take into consideration. One is that I'm not an interventional cardiologist, so I defer to Dr. Kassar and Armstrong, but heart artery blockages are short. Leg artery blockages are really long. And each little segment is its own little creature. So when you have a really long blockage with lots of calcium and it's really diseased, the chances of a really long stent staying open goes down. And so things that you can do to modify that plaque to get that artery closer to original, because when you're putting a stent in, you're just shoving the artery open. You're not modifying the plaque that's in there. There's a new technology called shockwave, which is intravascular lithotripsy. It's the same energy that they use to break up kidney stones on a balloon. It's really good for plaque modification in a calcified artery. And then drug-coated balloons have really, really good long-term patency as well. We have 5-year data that shows, long-term patency in the 80s and 90s in certain situations, and as good a long-term patency as stents in some cases. So really, drug-coated balloons are really great technology. Shockwave is a great technology. So there's these new tools that you can help to improve the long-term patency and push the endovascular envelope and try to minimize the use of stents. So basically, everything Dr. Kassar said, I completely agree with.
And I have one final. Go ahead.
Sorry, Kim, to interrupt. One other thing, a question came out about iliacs during that discussion, and that's a good point. In the iliac arteries higher up, stents are actually the standard of care, and they have patency rates that are around 95%. So if you have an iliac lesion and your doctor says that they need to stent it, that is actually what we routinely do, because the iliac arteries are larger. And it turns out that stents work extremely well in the iliac arteries, but below the hip joint in the SFA and tibials, that's where we were talking about reserving the use of stents for certain situations.
And my final question is just loaded. We only have, we're a little over time right here, and I want to get to our next panel, but this one, I can't have this session without throwing this question out there. There's a lot of scrutiny when it comes to atherectomy. And, I've been in thousands of hours of cases around the world, and have seen the benefits of atherectomy when used properly in the right hands and with the right tool and, the right indication, right? Removing, some of the plaque to make it more viable for that balloon. And maybe that balloon doesn't need to be as highly inflated because some of the plaque is removed. But there's a lot of scrutiny with some, with the high reimbursement for the use of it. There's some that are overusing it. So I wanted to get your take on that. And for patients that are going in and talking to their doctor about the tools and techniques, we encourage them to do so. What are some of the critical questions that they can ask their doctor to determine, hey, are you just going to use a wire and balloon? Are you going to use a roto-rooting device? If so, when, what kind, what are the indications for it? What would you suggest for these patients? Because I think it's a very important discussion to have prior to any procedure. We'll start with Dr. Armstrong.
Yeah, I think, Kim, as you said, atherectomy is a very important tool in our toolbox for treating peripheral artery disease. The reason atherectomy devices were invented is that they have specific applications for complex types of lesions. So I think when you're having that discussion with your doctor, the questions I would ask would be, what makes you decide to use a certain type of atherectomy device? Because there are basically two main categories of atherectomy devices. There are devices that are oriented towards treating calcium, and then there are ones that are treated more towards thrombus or soft plaque. And so if your doctor says they're always use a particular type of device, no matter what the situation, then I think that's a concern, because that's a decision that should be made once the lesion is looked at. And a good way to do that is to ask your doctor too if they use intravascular ultrasound, because that is an ultrasound inside of the artery that can really help determine how much calcium there is versus other types of plaque. And then that helps make the decision about what type of device to use in order to treat that.
Dr. Gulshan?
Yeah, I'm basically going to echo the things that Dr. Armstrong said. We have a lot of tools in the P.A.D. toolbox. The number of tools has really expanded exponentially over the last 10, 15 years. And IVUS is a phenomenal tool because it really gives you intravascular ultrasound, a really good visualization of the size of the artery, which we technically undersize when we're just doing an angiogram. It gives you an idea of, is there a dissection? Is there soft plaque? Is there hard plaque? And then it's not about, do you do atherectomy or not? It's really, what tool do you use, and is it the appropriate tool in that circumstance for that disease pathology? So shockwave for calcium, CSI for calcium. Drug-coated balloons are always a great choice. A stent with good radial force, if it's, calcified plaque and you need to push against it, a tack for a below the knee dissection that's flow limiting, but the compliance it's a soft artery because it's like a little staple and it can't push out. So it's a complicated question. There's a lot of tools, but I think it's a good sign if the physician says, I have a set of tools in my armamentarium. I do a lot of these procedures. I'm going to do what is appropriate in that situation, custom tailored.
And I think that that's really important. Dr. Khan, we always, tell people to ensure that their doctor is using IVUS, IVUS, that's the acronym for intravascular ultrasound, for the sizing and placement of balloons and stents, and to get to really understand the morphology, the type of plaque, that's in there as well, right?
Yeah, so I think if your physician says, we don't use IVUS at all, yeah, I'd be a little concerned, because I think physicians who use IVUS, I think they deliver better therapy and better long-term results.
Yeah, it's really important. Thank you so much to all of you for doing our speed round of questions and answering such a variety of questions. Dr. Khan, Dr. Armstrong, Dr. Gulshan, thank you so much from the bottom of my heart for joining us today. And if you have a chance before you jump off, there are a bunch of questions that are still lining up in our chat. If you wouldn't mind taking a few and just answering them, in text, we'd really appreciate it.